Welcome, everyone. We have a wonderful presentation for you all today on ethical practice and interventions in a hospital setting. And we have Alyssa joining us today, and we'll do our introductions as well. Next slide. All right. I said this a little bit ago, but just make sure your Zoom name is what you would like it to be. We're going to go through some housekeeping before we dig into the content of this presentation. So we are going to get started with our disclaimer. Next slide, please. Awesome. So you will all have seen this before. It's nothing new. This event was made possible, awarded by the Office for Victims of Crimes in conjunction with the DOJ. The opinions, findings, conclusions, or recommendations throughout this event are those of the contributors and do not necessarily represent the official position or policies of the U.S. Department of Justice. Couple housekeeping items for you all today. Again, you've seen these before, you'll see them again. Make sure you're muted unless you are speaking. We do have a small group today, so feel free to either raise your hand using that function, use the chat. Alyssa and I were talking before we got started, and because it's a smaller group, you're more than welcome to also unmute and engage with the content that way. But if you feel more comfortable using the chat feature that's at the bottom of your screen, feel free to use that. Everyone looks good in terms of their Zoom name, but if you need help with that, shoot me a message. And we won't be having breakout rooms today, but if you do have any technical questions or concern, my email is on the screen now, but the best way to reach me is just privately messaging me. And I will turn it over to Alyssa.
Sure. Hi, everyone. I'm Alyssa. I'm the supervising social worker for the Vulnerable Elder Protection Team, or VEPT, at Weill Cornell Medicine. Tony just called. He's super apologetic, but he won't be able to join us this afternoon because his mom actually fell and broke her hip. So he's dealing with that, but he says hi, sends his best, and was really sorry not to be able to join us. So here are the objectives for today's presentation. And we hope that after you attend this webinar, you'll be able to better understand the least restrictive measures taken in a hospital setting, identify common ethical challenge in hospital settings and how to mitigate them, next steps to be taken when working with a victim in a hospital setting, identifying differences between hospital issues and community issues. I think maybe we might not get that much into that, but I'm happy to have a conversation with that at the end, and how to coordinate or engage hospitals in navigating ethical challenges. So here's a little poll, which best reflects your work. Well, it looks like we have social work, APS, and medical services, which is a great mix. I think this will have, with this group of people, it'll be a really interesting conversation. So thanks for participating. And like Anna said, jump in if you have questions, but there will be time at the end. But I look forward to hearing all of your perspectives. So I'm going to start with a case, Ms. R. She's an 89-year-old female who lives in the community with her cat, and she was ADL independent, but used a rollator, had no in-home services. In 2019, she was hospitalized and discharged home to the care of her son. But when they went to discharge her, they saw the apartment was cluttered and the son was nowhere to be found. So EMS actually turned around and brought her back to the hospital, where she was admitted and discharged to subacute rehab. A couple years later, we saw her again. She disclosed physical and verbal abuse by her son, and she had gotten an order of protection against him. According to EMS, the home was still hoarded, covered in cat feces. Her capacity, I think this maybe got a little jumbled, this last bullet, but basically APS was involved but had closed the case, and her capacity to make medical and discharge decisions was kind of unclear during her hospitalization. So I think a lot of people here are familiar with elder abuse. I'll kind of blow through this, but we feel that the healthcare setting is an important opportunity to identify abuse because it may be the only time this abused older adult leaves their home. And hospitals are where you get treated for acute illnesses, like falling and breaking a hip or something like that. And the ED in particular might be a good place to find this because there's varied disciplines observing a patient. The evaluation, as Tony always says, despite best efforts, is prolonged, and there's resources available 24/7. But EDs almost never identify it, and there's a whole bunch of reasons why: lack of time, inadequate training. The professionals are fearful of the legal system. The patient may deny abuse. There may be ambiguities around their decision-making capacity and ability to report abuse, absence of a streamlined protocol to handle the abuse, difficulty distinguishing abuse from accidental trauma. And that's kind of the biggie here. I don't know, we transferred these slides over to this format and I think we got some wonky stuff. So sorry about that. So to help EDs better identify abuse, we designed the Vulnerable Elder Protection Team, or VEPT, which is the first of its kind hospital-based multidisciplinary team that's available 24/7 to assess, treat, and ensure the safety of victims while also collecting evidence when appropriate and working with authorities. And we hoped this would increase identification and reporting while decreasing burden on providers. And it's similar to child protection teams. So elder abuse cases have a lot of complex ethical issues, as we all know. And the hospitalization is perhaps an optimal time to address these issues because the older adult's outside of their home and we have a lot of resources. So these VEPT programs, we actually, in Colorado, another program modeled after ours was launched. So we feel like ethics is becoming more and more prominent as these multidisciplinary teams are developed. So we looked at our VEPT cases and saw when ethics was consulted. And we divided these cases. We looked at characteristics of these cases, reasons why ethics was involvement, and their recommendations. Sorry, I'm feeling a little out of breath for some reason. So VEPT was consulted not 48 times. So that's 7% of VEPT consults, and 9% of all of our admitted patients. Ethics doesn't get involved in the ED. And you can see we've used ethics quite a bit with increase in frequency, which means that we feel like they're helpful. And these are the breakdown. I won't read all of this, but I had some animation here that got lost. But ethics was most often involved in neglect cases, when there was cognitive impairment, and when there was concern for high concern for mistreatment. And these are the reasons ethics was often consulted. We needed to find a surrogate. The surrogate was the abuser. The surrogate wanted the patient to go to the unsafe home. The patient wanted to return to the unsafe home, or the surrogate was not in agreement with the care plan. So ethics provides an opportunity for all the hospital stakeholders to meet and talk about the concerns and kind of create a unified approach to managing their care. Ethics and VEPT also reach out to other hospital teams like patient services and legal and geriatrics so that everyone can come together with their unique backgrounds and decide how to best serve this patient. So what do they recommend? They often recommend working with the healthcare proxy, even if they're the abuser, unless they're no longer making decisions that are in the patient's best interest. Ultimately, we all want to serve the patient. So that's the ultimate goal, even if we feel like there's an abuser that's questionable. We also have to make an effort to align with the patient and family to create a therapeutic alliance and hope that they'll become more receptive to what we're recommending. In cases where the surrogate does not want to listen to the medical team, we find it's extra important to spend time with them to really try to align with them, validate maybe what they're going through if they're burnt out or whatever's going on, so that they ultimately are making what we feel are choices in the patient's best interest. So despite our best efforts, the hospital sometimes has to discharge patients home when it's maybe not the safest. And so a referral to the EMDT to ensure follow-up in the community can be critical. It allows for continued conversation about these complex cases. And we know that these patients aren't just going into the abyss. There's going to be some kinds of follow-up. And maybe members such as APS can go and do a home visit and see what's in the home, because we don't get to see that. And if a patient's already known to the EMDT, this is really important for us to know so we can kind of get as much collateral as possible. Which might help shape what we decide doing with the management of the patient. So the ethics team makes important contributions to the hospital management of older adults and is really critical to their care. Ethics is most often involved when we can't identify a safe surrogate decision maker or we question their motivations. And typically the recommendations involve working closely with the family, even if concerns exist, to try to best serve the patients. And ethics at times will even reach out to collateral sources on their own, so we can really get a holistic view of what's going on. VEPT is doing a lot of collateral, ethics is doing a lot of collateral, but it's helpful for us all to kind of do that work if we're able to, so that, we all have different perspectives and different kind of ways of judging safety and conceptualizing a case. And I think doctors have different perspectives than social workers, than nurses, than physical therapists. And so the more people that are involved and the more people that are getting, different information, the better it is for when we all come together as a group to decide what's the game plan, how are we going to move forward. And I think sometimes that can be a little sticky when we have different stakeholders. But I think that's the beauty of teams like VEPT and in conjunction with ethics to kind of give everyone that opportunity to express what they think is best, and then coming together to create a game plan that we're all in agreement with. So, sorry, I kind of started rambling, but I kind of was saying this, I guess, that the ethics consultation process really allows an opportunity for all of us to come together. It's a safe space for all of us professionals to voice our concerns and talk about what we think are the right next steps. I think kind of what I was just saying, we all have different backgrounds personally and professionally, and different values based on our own personal experiences that kind of help shape how we conceptualize these really complicated cases. And so I think ethics provides an opportunity for us all to come together, feel heard, and kind of remind ourselves of our shared goal, which is the patient, being patient-centered, maximizing safety. I think when we're dealing with abuse, it can be really, really hard. Like sometimes you don't want to work with the abuser. You're like, this person, hit this person, or, the patient's son is using drugs and stealing her money to get drugs. And why should we be listening to this person? They're obviously really struggling and not best serving the patient. Yet usually we're advised to keep working with that individual because at the end of the day, that might be the only individual this person has. The older adults are usually really isolated, and they maybe only have that abusing son, but that son is better than nobody, or better than them ending up in a nursing home, which most people really, really, really don't want. So I think it's, important to keep in mind that this work is really hard and really complex, and these ethical challenges are not easy, and sometimes we don't feel good about what we end up deciding. But I think keeping this this shared goal, this mindset of what is going to be the least damaging, like I'm sure we've all seen patients end up in a nursing home and they decline, and even though home wasn't great, it's better than that. So it's kind of having ethics to help weigh these issues is really, really helpful. So we hope to conduct additional analysis on these small subset of cases and identify opportunities to work even more closely with ethics. We'd also love to share our experience with our ethics team and provide guidance to other institutions. I think not all hospitals have ethics, I don't think. So potentially working with hospitals who don't really have as many resources, how can they, maybe it's finding a champion or someone who's interested in these issues to learn more. We don't know what that looks like, but I think it's clear to our VEPT program and the program in Colorado that's modeled after us. We both work very closely with ethics, and I think it's a really important part of our work and something we should all try to be mindful of when we're handling these sensitive cases. So back to Ms. R, when she came back after the abuse, we had a visitor restriction against her son. Psychiatry was involved to try to continue to monitor her capacity. Geriatrics was also falling because she was having some delirium, which also impacts her capacity. So it was really complicated. It was like one day she had capacity, the next day she didn't. And so it was really hard to know what to do. Ethics was consulted due to concern about her safety at home, and she was consistent, regardless of whether she was with it that day or not. She wanted to go home to her cat. That was incredibly important, which I think is really interesting. The whole pets with elder mistreatment, I find to be a fascinating area because there's such an important support system for older adults who tend to be isolated. And I even find with my dog, like I would never want to be away from my dog, and I'm not a very isolated person, but it's really such a important thing for older adults that they don't want to go to even subacute rehab that's temporary. Like they're very concerned about their pets, and understandably, because who's going to take care of them? Sometimes they don't have anybody, and it's really a real issue. So she was discharged home. We ultimately decided she did have capacity and was consistent in her wishes that she wanted to go home. APS had closed the case, but we had them reopen. APS and the management of, I know there's people from here from APS, they were amazing. Like the best APS team ever. They opened the case again while she was in the hospital. And we were able to coordinate with them the scheduling of a deep clean on the day of her discharge. So she went home at like 9 a.m. on a Tuesday, let's say. APS met her at home and did the deep clean with her there on the day she went home. I also called NYPD to do wellness checks on her. She was, involved with the domestic violence officer unit already because of the order of protection that had been issued. So they were going to continue to check in on her. And she also was going to be followed by the EMDT meetings, which I also attended when to help with the conversation. So the other thing I didn't write was her building management was also top notch, and they were very involved. We let them know that NYPD was going to be coming, that APS was doing a clean. They were very, very involved. And they called me after she already left and were like, things are going better. We're less concerned. Like she used to be wandering. She's not wandering anymore. So it was good that, we had another set of eyes there. What was I just going to say? I lost my train of thought, but they were awesome. And so it was really good to know that we had kind of these eyes in the community that were following up, even though we were kind of like, what's going to happen with her son? The son did end up coming back, and he was present. I think he stayed with her for a bit, but it was what she wanted, and everyone felt that she was able to make that decision. So that's kind of it. I know the building was super nervous about that as well, but it seems okay. And I haven't seen her since. So hoping all is well with her. And it was a really, really challenging one, though, because there's this order of protection. She had physical signs of abuse, and all she wanted to do was go home. And the cat was a big thing. So it was hard to kind of say, okay, we're going to send her home feeling a little bit icky, but I think it was ultimately probably the right thing. So that's all I've got. I blew through that. I'm really sorry. But I'm happy. Like, I'd love to have conversations. I'd love to hear about, those of you working in the community, what type of ethical situations you encounter, or if there's hospital folks here, how maybe you handle these types of situations. I'm really interested in how other people are kind of managing. And these are Tony's kids, by the way, and this is my dog, Poppy.
Thank you so much. That was super informative. And that case study was just, I feel like when we use case studies a lot, they don't always have a happy ending. So I'm happy that
it might have been cherry picked, but it was all real. I don't know if it's a happy ending either. The son is, last I heard, he's back in the picture. So who knows really, but hopefully all is good.
Yeah. Do we have any questions regarding anything that was covered? Any real world examples that you want to share?
I can also go back if it's helpful to some of the stats that I kind of blew through, if that's interesting to people.
I've got a quick question. In regards to the hospital determining that this client had capacity, what does that look like, especially in an emergency room setting? Because sometimes I feel like we get like, oh, they're decisional, and there's some significant concerns, and they're not going to come in and have somebody do like a full capacity evaluation. So how does that look like at your hospital? Or I guess, what does that look like at your hospital?
Question. So it's not a global capacity evaluation. It is decision specific. So in this instance, the question was, does this patient have capacity to discharge plan? Does she understand the risks of going home, that it's hoarded, that the son is abusive? It's very question specific. It looks the same, whether it's the ED or the inpatient unit. We tend to, any medical providers, I'm sure, can make this type of determination on their own, but when it's kind of these stickier cases, we tend to recommend consulting psychiatry versus psychiatrist to do the assessment. And the assessment is them, we have to tell the psychiatrist, this is the question we want to know they have capacity around. And it's usually, do they have capacity to discharge plan, given that we have these concerns in the community and the recommendation is rehab and they want to go home. So they go and have a conversation with them and try to determine, does the patient understand the risks and benefits of refusing the recommended discharge plan. Hopefully I answered your question a bit.
You did, thank you.
Alyssa, there's also a question in the chat. What types of issues have you had with HIPAA concerns?
In terms of getting collateral, or we don't usually share medical information or patient information with others unless we have permission from the patient or the proxy. So we haven't.
Well, how does it work when you're working with EMDTs or APS, like you mentioned, on cases? How are you guys, sharing information that way?
So APS is, Kylan, you're on. I recognize your voice. Hi. APS is usually HIPAA exempt. So we don't usually have an issue sharing with APS. I think I try to still, out of respect for the patient, only share what I think is critical for APS to know, for them to manage what's going on. But APS, as far as I'm aware, is HIPAA exempt. And then the EMDT has great policies in place. We don't say the client's name, protecting super identifiable information. But I don't know if any of you guys know Dr. Ronnie LaFaso, but she's a geriatrician at our hospital, and she's met with legal several times. And I think really the takeaway, this is not legal advice, so no one really go about doing this. But like at the end of the day, what we've kind of been told is, if you're working in the patient's best interest and information needs to be shared for their safety, I kind of share it. I don't go sharing everything. And I think, things like psychiatric stuff, there's, sensitive HIV diagnoses, there's things that you don't need to share. But when I'm working with APS, especially, I think we have a shared goal. We want to best serve this person. And if they need information they obviously need information about the patient in order to do their work. So, that's kind of how we do it. It is a really gray area, though. It's something I actually wish I knew a lot more about. But when outside APS and outside the MDT, I usually only ask for information, and I'm not usually, when I call a PMD or if I call a case management agency, I'm asking for information. I'm not sharing information unless I get permission from the patient.
And in your opinion, what might be the best way for EMDTs to work with emergency room personnel in regards to an elder abuse case?
Get a VEPT program. I think having someone like a doctor from the, if possible from the emergency room, or if not from the hospital, just having a member from the hospital as part of the EMDT. I don't know if that's standard across all EMDTs or not, but I think that's the best way is, somehow making a connection. Even if it's not a doctor, if it's a social worker that works in the ED or in the hospital, I think it's all about relationships. Like, I think my working relationship with APS has gotten so much better from when I think about when I started 6 years ago, because have friends, you become friendly with your coworkers and you want to help each other out, and you want to be there to, support each other, bounce, questions off of. So I think having a point person at the hospital is probably the most important thing. And if you have a point person and they're not part of the EMDT, maybe seeing if that's something they're interested in, so they feel part of your team and part of your group. I think personal relationships to me have been the best way of engaging agencies that you need to engage. So I think that would be my recommendation, is just trying to identify someone in the hospital who's maybe interested in this work to join the team.
Alyssa, I had a question about the ethics team that you have set up. I'm a little unclear about how it is set up. Is it a regular standing committee that gets convened every time there is an ethical issue for VEPT, or does the hospital already have an ethics team? And in these meetings, are you a part of those discussions? I'm thinking around the parallel for EMDTs, like in the absence of being plugged into a hospital system, what should they be doing in terms of either constituting it, or is it a question of, for one, during an EMDT, we're going to spend some time thinking about the ethical dilemmas very specifically?
I was actually going to ask, something like that, if you've ever considered having like some sort of medical ethicist on these teams, or, I don't even know if it's necessary all the time if they are a consultant or whatever, but basically how our ethics team works is there's an ethics committee, and that has tons of people from the hospital who are part of the committee. And the committee, I think they meet once a month, and they discuss some of the challenging ethical cases. These are not elder abuse cases necessarily. It's hospital-wide of all the patients. They pick like a couple to talk about once a month. And I think like Lisa Rackmuth is on this committee, Tony's on the committee. It's like a huge committee, and it's not just ethical people, it's all sorts of stakeholders from the hospital, and they meet and discuss a couple of the ethical cases that the ethics team has seen over that month-long period. How ethics works in like the clinical day-to-day practice is they're a consultation service, much like VEPT is. So they're on call. You can consult them at any time if there's an ethical dilemma. And there's always like a primary person on call, and then there's a fellow. So they have a fellowship program where they're training medical fellows. They're usually medical, although not everyone on the ethics team is medical. There's some psychologists, there's a nurse. So there's a little bit of variation, but it's mostly doctors. And so at any given time, there's a doctor and a fellow that's on call, and you page them and they call you back and say, how can I help you? And I explain what's going on, and they'll say, oh, this sounds really complicated. Thanks for calling us. And they'll usually then call the primary team, the physician who's managing the case. They'll call the primary social worker. They get all of our perspectives on what's been going on. And if there's community agencies, sometimes they'll reach out to the agencies like APS, not all the time. And then usually they go and meet with the patient if the patient's able to communicate and ask the patient what's been going on. And then ethics will arrange for a meeting. So anyone who's been involved can join. They'll kind of create a Zoom in this COVID day and age, and it'll be VEPT and ethics and maybe patient services and the nurse and the doctor and the PA and physical therapist. anyone who's kind of been involved in this patient's care will join, and we'll all kind of talk. This is my perspective. We usually start with a medical doctor. Tell us what's going on medically, and we just get a medical understanding. Then I'll share the abuse concerns, and we all kind of share what we know, and ethics kind of works in real time to sift through everything we're sharing and say, this is our ethical analysis, and these are what we think are the next steps. Next steps is social worker is going to have the patient complete a healthcare proxy form, and VEPT is going to talk to NYPD to get information about XYZ or something like that. We kind of come up with a game plan, and then ethics is available as needed to touch base with if more concerns kind of arise, or if we do the next steps and we're like, okay, we did these things, but like still now what? And it's kind of like they don't tell you what to do, but it's kind of a good way to like all get, continue to be on the same page and kind of dot your I's and cross your T's, because the worst thing ever would be that somebody goes home and something really bad happens. And so that's ultimately what we want to prevent from happening. And God forbid something bad happens, we can say every single person involved in the care of this patient met, and we got ethics involved, and we got patient services involved, and we got legal involved, and we all decided as a team this was the decision we wanted to make, and we did the best we could, rather than not doing all of that and someone goes home and something bad happens and it's like, well, why weren't these issues discussed?
Any other questions? All of these have been really great, building off of what we've learned in the past 45 minutes. Thank you so much, Denise and Kirk and Grace and Kylan, for those questions. Anyone else in the chat, or feel free to unmute. All right, I'm not seeing any. Thank you so much, Alyssa, for sharing your.
I went really fast. I'm so sorry. I realized I was
That's
like
okay.
by the end. Sorry about that. But hopefully this is interesting. I don't know.
Yeah. I'm going to drop a evaluation link in the chat. Feel free to fill that out with any feedback about our content, as well as what you would like to see more of. We will, if you would like a recording of this session, it has been recorded. So let me know if you have anyone on your team that you think would benefit from learning about ethics in a hospital setting. And I hope you all enjoyed your time spent with us today.